That's good.
I can be talking that, but I've done the half. Is there a flat rate?
All right, everyone, I think we're gonna get started. So today we have Michael's resident report, but I was gonna just start us off with a UWorld question before that. And so if we could have someone in maybe the front row or front few rows read us the UWorld question, please.
A 23-year-old woman with a 4-year history of ileocolonic Crohn's disease comes to the physician complaining of gas and feculent vaginal discharge for the past 2 weeks. She has no fevers, chills, abdominal pain, nausea, or vomiting. She's been treated with azathioprine for her Crohn's disease without any recent flares. Meds include vitamin D and B12. Her blood pressure is 100/60, pulse is 72, respiratory rate is 14. Exam is soft and non-tender abdomen without hepatosplenomegaly. Rectal exams within normal limits, pelvic exam unremarkable. MRI of her pelvis shows fistulous tract from the rectum through the vaginal wall with surrounding edema, which is the following is the most appropriate step in management. And then in terms of her labs, she has a lower hemoglobin at 10, borderline MCV at 80, platelets are 280, leukocyte 6.7, so normal. Sodium is 134, so on the lower end. Potassium is a little below 3.4. Chloride's 110. Bicarb's 20. BUN 6. Create's 0.9. That's both normal. And glucose is 84. Her ESR is high at 40. Options are A, infliximab, B, mesalamine, C, observation, D, prednisone, or E, surgery.
What are our thoughts?
So they're asking like somebody has a vesicular like fistula,
Rectovaginal, yeah.
Yeah.
Mhm.
and like whether there's surgery or you want to get like medical therapy.
Yeah, what do you guys think? So we have surgery. How many people think surgery? Any other ideas besides surgery?
I mean, you could.
I think
probably-
prednisone is a reasonable option. I mean, if you could be counting this as a flare and see if you can get things under control with prednisone prior to surgery.
Mhm.
But I feel like surgery is the ultimate.
Any other ideas?
Because it's asking for like most appropriate stuff. If it was like what's the immediate next best, that's and maybe you could say pred. But I think rector vaginal fistula is probably very debilitating. So you can't just pretty much 3 minutes that you have to.
Okay.
In a 23-year-old.
I'm going to say surgery, but I would say that because of how stable she is otherwise, her symptoms, I feel like you're lying.
Yeah, she's pretty stable, and she has, I would say, moderate to severe symptoms. I guess I would describe moderate to severe symptoms being like gas and feculent vaginal discharge in the past 2 weeks. How do we normally treat like fistulizing Crohn's disease?
Well, if it's a flare, you have to calm the flare down.
Yeah, how do we treat like maintenance therapy outside of flares?
There's some sort of biologic.
Yeah,
Like infliximab.
like infliximab. Yeah. So the answer to this question is actually A. And so I think I'm gonna like rephrase this question as just how do we treat the initial management for moderately or severely symptomatic rectovaginal fistulas and Crohn's disease. And so we have UWorld has a kind of guideline on the right for us, but essentially in a rectovaginal fistula, if it is IBD related, then we assess the severity of the symptoms, and if it's just asymptomatic, we observe. If we have mild symptoms, then you can treat the patients with a course of antibiotics to see if those mild symptoms improve. Typically, those antibiotics would be, I think metronidazole and Cipro. Moderate to severe symptoms. The first agent with the best evidence is going to be TNF alpha inhibitors, such as infliximab. And then from there, if there are persistent symptoms, then the patients can proceed to surgery. So I think that's the learning point in here. In addition to infliximab for fistulizing Crohn's disease, you can also use thiopurines, which our patient was already on, or tacrolimus. In general, approximately like 20 to 30% of patients with Crohn's disease will develop anorectal fistulas. And of these patients, about half of them actually present with their initial diagnosis with anorectal fistulas as well. So about 15% of patients will have anorectal fistulas.
For me, the big takeaway from this one was, just quick in reading it, was the fact that the algorithms immediately, is this IBD related
Yes.
Or is it non-IBD related?
Yes.
Because basically, I haven't come across non-IBD related, but I haven't come across IBD related, but I have come across non-IBD related. All of those, like if it's a post-surgical complication, which is where I've seen it most commonly, or in the setting like colorectal carcinoma, that is go to surgery. But because specifically it's IBD related, that's your algorithm, and that's where you think about how you can manage it medically rather than go through.
Nice. Did they mention anything about prednisone in this situation? Because it feels like a departure from like clinical practice versus like what they want as the answer for this question.
That's a good
Because I feel like
question.
most patients that would come in with any sort of IBD related flare are at least getting a trial of prednisone before anyone pulls a trigger on a biologic on them. So I find it interesting that it like goes straight to biologic, and I wonder what the reason is. would be
That's a
for
good
that.
question. I don't know the answer. My presumption is actually that in reading more about this question, I don't think this, I might be wrong on this, and maybe Ali can back me up in too, but like, I don't think that this is actually a flare of Crohn's disease. That her ESR is 40, which is only slightly elevated. She's not having symptoms of like severe abdominal pain and new diarrhea or any new blood in her stool. And so I think this is more the symptoms related to the fistula, and then prednisone may not actually have an effect for this case.
Yeah, that makes sense.
May also be the shift. General shift now is to try and get steroid sparing therapies on earlier,
Yeah.
especially if it's the fistulizing. What I clarify. So I might get for some of this, but I'm on by.
Yeah.
Might also be an insurance issue, you know, like they're not gonna cover infliximab without a trial of steroids for.
That's true.
All right, I'll let
Unfortunately,
Michael
Dr.
take over.
Webber could not be here to answer that question. Okay, so we're gonna divert from Crohn's for a hot second. Yes, it is. There's no good questions on my topic, really. I looked for hours last night, and they're all kind of a little too straightforward. So I titled my case presentation "The Study in Saffron," which is a kind of pun off of a Sherlock Holmes book of A Study in Scarlet. And the reason I did that is A, because saffron's a yellow color, and we're going to be talking about the jaundice patient. And B, the topic in general feels very detective-y whenever you come across what's going on here. So we are going to start off with a 41-year-old female who presents to the emergency department with new onset fatigue and painless jaundice. What would you guys like to know about this woman?
The fatigue stuff.
It was only like a day or two ago.
The jaundice stuff.
Same thing. She noticed it in her eyes about a day or two ago, and then her husband noticed that her skin was starting to get a little yellow.
Any abdominal distension?
No distension.
Do you have any past medical history and showing the patients?
Yeah, so she has a history of ulcerative colitis, a history of hypertension, a history of hyperlipidemia. And meds-wise, she's on lisinopril, simvastatin, prednisolone, or sorry, not that, that's an older one, and then the vedolizumab.
And the last one, Ian?
The vedolizumab, which is a monoclonal antibody for UC.
Oh,
I would like to learn more about like her social history, smoker, drinker, drugs.
Social history-wise, she's a never smoker. She has 1 to 2 glasses of wine a week with dinner, and no drugs.
Any fevers?
No fevers.
Shipping any UC symptoms like diarrhea?
No flare symptoms, no.
Any belly pain?
No belly pain.
Taking any pharmaceuticals.
No herbal supplements. Good
Any
question.
rash?
No rash.
Does this ever happen before?
Never happened before.
Any recent stressors in her life?
No recent stressors, no.
Was she
Not a-
born?
Huh?
Jaundice?
She was not born with jaundice. Okay, so let's hop in. Ignore the prednisolone. I had adapted this case from a little bit more of a complex case, and I sliced it down a little bit. She's not on the prednisolone, okay? But she is on the lisinopril, simvastatin, and the vedolizumab. This is basically the presentation you get for her. You guys kind of hit all the points for the most part as far as what really came up in her case and what the issues were with her initial presentation. Physical exam wise, when you're seeing her, Vital signs are normal. She is jaundiced. She does have scleral icterus, and everything else is about normal. On palpation, you get a little bit of tenderness, but otherwise she's not really complaining of anything abdominally. So the question I want to pose to you guys is, what kind of differential are you going to come up with for painless jaundice? And how would you like to think about that differential if we want to put it into buckets? Get up on the...
I usually think kind of pre-liver, liver, post-liver ratios.
That's also how I like to think about this in particular. I think a lot of the times we think system-based for a lot of our differentials, and I think it's a good practice sometimes to think physiologically based for things. So if we're going to go pre-hepatic, and post. Do you guys want to, what are you thinking of?
So pre-hepatic monocytes.
Yep. And we can do big buckets. You don't have to go straight diseases. So we can do hemolytic.
Enzyme deficiencies.
Yes, enzyme deficiencies are going to be in our hepatic enzymes. Obstructions. What kind of obstructions? Okay, biliary obstruction.
Pancreatic.
And that's going to fall under here as well. What else are you thinking of?
Conjugation issue.
That's going to go under your genetic enzyme disorders for the most part. If you're thinking about like, what do you think
Don't
about?
have like vascular.
Yes, vascular could fall in to our, where did I put our vascular? That's going to be our in here. So if you're thinking vascular wise, you'd be talking about something like a Budd-Chiari syndrome or something that's actually causing like backflow and getting you cirrhosis at the end of the day.
Hepatitis.
Hepatitis. Infection in general.
Toxic or drug abuse.
Toxins. Great.
Cirrhosis.
Huh?
Cirrhosis.
Sure. Like chronic liver disease.
Wasn't there a group of diseases where the liver can't uptake from the bilirubin, like from the blood? It's like pre-hepatic, the liver can't really uptake the to conjugate.
Are you thinking of, what are they called? The OTC disorders, like the,
Ornithine transcriptomics.
thank you. Smart man over there. Yes, we're gonna pop that into genetic as far as any sort of inability for the body to conjugate or deal with bilirubin. Autoimmune. Yes.
You say meds early?
Yeah.
Yeah.
Digestive epithelium.
Yep, we're gonna put that under vascular. And I think you guys got most everything.
The thing I say is shock liver.
Shock liver could do it, yeah.
And then you can have.
And I kind of have that in.
I call it pre-hepatic because you're not perfusing
It is. It's more of like there's like a weird area where sepsis/shock liver live.
Yeah.
Where it kind of is a prehepatic and intrahepatic and everything's kind of damaged.
I know you can have some like, I guess they would also belong to vascular, but like splenic, if you have like some like splenic pathology, could potentially like.
Trauma, I think can, but it's
Like,
not really in a more of this like painless jaundice differential, because if you're having trauma, that's enough to cause like
liver lack.
anything. The only other thing I have under here is like a metabolic / endocrine issue. Let me pop over here. So you guys hit all the high points. I don't want to kill too much time on the differential. So as far as our hemolytic anemia is, just to review some of the stuff that you could see that could be causing this. Often we could see it with sickle cell patients or hereditary spherocytosis. You could see G6PD. all of your autoimmune hemolytic anemias, as well as like malaria, hypersplenism. All these things can cause a painless jaundice that you could see. You could be having ineffective erythropoiesis with things like thalassemia and different megaloblastic anemias that could also cause it at the end of the day. In our actual hepatic area is where you're going to see a majority of the pathologies, just like you guys came up with. You could see it with your chronic hepatitis. You could see it with cirrhosis, fatty liver disease, alcoholic liver disease, all fall in that chronic liver disease. A lot of the stuff that you guys were bringing up were in these genetic disorders of bilirubin metabolism, which into there falls like Gilbert, Kriegler-Najjar, Dubin-Johnson, and Rotor syndrome. They all are fun ways of us not being able to metabolize bilirubin appropriately. Tumors everywhere can always cause issues of blockage, whether it's intrahepatic or posthepatic. You're going to have a potential buildup of bilirubin eventually. And then we talked about biliary obstruction as well. So, fun differentials. We have a lot of reasons why this lady could have jaundice. What's the next thing you guys want to do?
Labs,
Yes. Do you want to do any specific labs?
complete metabolic panel.
Sure. I'm not going to give you that though. Most of it's normal.
G6PD enzyme assay.
Sure. That's going to take like 4 weeks to come back.
CBC first.
CBC is normal.
Yeah, LFTs.
LFTs are abnormal and elevated.
Which one's elevated?
Yeah, which ones?
Okay, so these are the labs you get. This is what you see, and I want you guys to think about what this could be at this point. And what do you notice? What's the things that are sticking out to you?
Definitely, bilirubin is definitely elevated with a direct predominance.
Sure.
It's like cholestasis pattern.
Is it posted?
How would you find that out? Whether it's cholestatic or hepatocellular?
I look at the T-billy and alphas, and they're both elevated. It's generally guided towards a like a biliary versus just liver.
So, partially, yes. There is something called the R factor that you can do, which is it's on MedCalc, you can pull it up. I believe it looks at the ALK phos and the ALT and compares the ratio of the two. That will then tell you whether you are a cholestatic predominant liver injury or a hepatocellular predominant liver injury. So it's looking at the ratio and saying, do you have more signs of bilirubin being built up, or do you have more signs of like cell damage being built up? In this particular case, I believe this ends up being hepatocellular damage. This isn't necessarily cholestatic.
It actually refuses the ALT just
Because it's so high. What else do you notice about these labs? Anything in particular we like to look at with ALT and AST?
Like the ratio.
Correct. So our AST to ALT ratio is less than 1 in this scenario. Likely, this is something that you'll commonly see with what we're looking at in general. The ALK phos and GGT and bilirubin in general can be very variable in this disorder. And then you'll often find very nonspecific image findings like just hepatomegaly. Does anyone want to take a gander or guess at what we're looking at?
A couple things. So like this patient is coming in with like a background history of like ulcerative colitis, which in itself is like an autoimmune disease. So I think the fact that we did a pretty comprehensive autoimmune panel, including for autoimmune hepatitis, which could cause jaundice and liver injury, and then I think less likely in this case, but like PBC as well, like was I think important in this case to rule out like an autoimmune component. You could also see like an extensive infectious workup to evaluate for any like liver injury from the infection that was also negative. So see the patient is like vaccinated for hepatitis B, and has been exposed to EBV and HSG in the past, but is IgE negative. So just thinking about those things as well, because I think even in comprehensive work, patients coming with abnormal LFTs that are pretty severe, they now have symptoms related to that. This is something that you're going to be extensively working up to look at every etiology that might talk.
So if we take it back to our differential, this panel of labs that we have basically rules out almost everything, right? So her CPC was fine, and she's not in sepsis or shock. So you basically have nothing going on with your prehepatic regions. Imaging didn't show any sort of obstruction going on, although it's just noted as an ultrasound there. We'll say that the imaging was sufficient to rule out any sort of post-hepatic mass. If we're looking at our hepatic issues, she has no history of having jaundice before. It's unlikely that this is her first presentation at 41 of having Gilbert. No signs of infection, no vascular issues that were found, no history of liver disease whatsoever. Her autoimmune panel was negative, and no sort of other underlying like hyperthyroid, hypothyroid issues that are causing a backup of anything. What does that leave us with?
Awesome.
Deal. So that's what we're going to talk about a little bit. If anyone remembers this commercial, it's very funny. I couldn't figure out how to get the audio going, but we're going to talk about Dilly. So if we pop into Dilly, this patient in particular, one question that you guys missed when we were talking about what her presentation was if she had recently started any of these drugs or if they were new drugs for her. In particular, her vedolizumab had just been given her second dose ever. She had her initial dose about 15 weeks ago, and then her second dose was given 2 days prior to her presentation. And you can, so the theory was that she had a drug-induced liver injury from her vedolizumab that she was getting treated with for UC. And basically they decided to stop it and see what was going to happen. If we actually look, this was her timeline of labs as she came in. She came in on like day 2 after infusion, and they got stopped in the hospital. And then you can see everything just kind of trends down from there. And that's kind of one of the bigger talking points of Dilly in general. There's not a whole lot that we do for it. We have to figure out what caused the issue, and we need to stop it. There are a few assistive things that you can give, but it's very rare that you'll be asked about it, I think. And I think they're often used as red herrings. But if you have a patient that is hyperbilirubinemic and having symptoms of that hyperbilirubinemia, like pruritus, you can give ursodeoxycholic acid to help clear their billy. But I've seen that used as a red herring in like mix-app questions, where the real answer that they want is just like stop doing anything and just trend and hold the drug that you think is the actual cause. Can anybody think of some common causes of a drug-induced liver injury? Yes, antibiotics are a huge one. Tylenol is a huge one. Antiepileptics are a big one. Antipsychotics are a big one. Yep. So as we hop in, Tylenol is going to be the most common thing we see in the US, usually because of either intentional or unintentional overdose that can cause acute liver failure in general. It's important that basically this is one of the other things that you would actually do something to treat and you would give NAC for. The other big thing we're going to see is antibiotics, especially Augmentin. Worldwide, Augmentin is the kind of #1 culprit as far as causing drug-induced liver injury. In addition, I think NSAIDs are often forgot about, that they can cause this. The mechanism is not understood well. I tried to figure out why that happens, but it's not known, but they can do it. So be conscious of patients that have like recently started on, some sort of NSAID for, an injury or something, and they've been on it for weeks, and then all of a sudden their liver enzymes are through the roof. And finally, 60% of the cases worldwide are due to antibiotics and antiepileptics. So your majority of your culprits that you're going to see is someone who was on a short course of antibiotics for some whatever reason. They got augmentin, and then they appear with LFTs and the 600s for whatever reason. Big thing that just to touch upon, herbal supplements and traditional medicines also have a lot of issues with this. That's why I liked An's question of, is she on any supplements at home or like herbal things? I think they often get forgotten, and we often forget to ask patients about what other off-brand things they're taking at home. Kava got really big for a hot minute, and then a lot of people had a lot of liver injuries from it, and it's not so popular now. But the one thing that I wanted to make sure we talked about was liver tox, and that everybody was aware of what this is. How do I get a clicker? Hello?
We go to the top, maybe, might be able to like change the.
What if I come up here, actually? Can I click here?
If you minimize though, it's probably open.
Does everybody know what this is? Okay, great. We're gonna pull it up for a hot second. If anybody's never seen this, it is an NIH resource that is specifically revolves around liver injury. So you can find just about any drug, almost any drug that you can think of in here. If you're worried that it may have been a cause of a liver injury in your patient, on top of just having a bunch of useful info on all these drugs and how they interact with the liver, you also get a likelihood score of it being a agent that would actually be the causative agent. So you can take your patient's drugs that they're on, look them up, look into here, and really see what you can think of as the most likely reasons why they could be having a DILI and what you're trying to stop and trying to withhold for them. Just some info on, sorry, let me get my PowerPoint back up. Just some info on what you're seeing there, because you're going to see like basically they have categories between A through D, and then, or sorry, A through E with an X category as well. A is like very well-known cause of liver injury. That's why Tylenol had a category A. B is a like likely known cause where they had like 12 to 50 case reports. They have good enough evidence to say like there's a good chance that this could actually be a drug that would cause a liver injury. C is like a handful of case reports that they've seen of liver injury that's being seen. And then D is like they're pretty sure that it's not actually going to be causing something major. It might be like 1 or 2 cases that they've seen. Oddly enough, the vedolizumab in this case is actually listed as class D, which is why that case report was published in the first place, because it's not really commonly seen for that drug to cause a liver injury. And then E is like, despite them extensively studying it, there's like no cause of liver injury. The X is just like recently introduced things that they just don't know what it does yet. So big learning points I wanted to focus on for this was, 1, don't forget to ask about the new medications and what kind of new frequency people have been on medications. A big thing for DILI in general is clinically, you need to rule out other causes of liver injury, and you need to also show the temporal relationship with the drug. You can't have somebody that's been on a drug for like 9 months and then you're like, well, it's this. And you're like, well, maybe not. It should be a recently new drug. It should be a recent dose that they had that set this off. Do you have a question on?
Yeah, because I think this happens a lot in patient versus outpatient as well, where patients come in with abnormal LFT and the statins are stopped.
Yeah.
And they've been on statins forever. So I wanted to know if there's any evidence out there of like actually supporting that.
Stopping statins.
And also, is there any time frame can patients develop DILI while on statin after being on it for years?
So as far as the actual data, I'm not certain off the top of my head. I don't necessarily, statins are very rarely a cause of DILI. That I do know. I think the reason often they get stopped on the inpatient side is the fear of statin metabolism being decreased and therefore you having statin side effects. Not necessarily that the statin is the cause of the liver injury. And I think they're often prematurely taken off. Ollie, do you have anything to add on that?
And then statins, they sometimes will also go with
Mhm.
muscle breakdown, which then will cause another disease. So sometimes they're like that. But like you said, I don't think it's one that will cause the plastic, but it can sometimes.
So I don't think you have to be as afraid of stopping someone's statin. At the same time, in the inpatient setting, we're taking like utmost caution with people to not put them at more risk when they're already in a frail state. As an outpatient physician, like getting your patient back, if their LFTs are within range, I don't have any worry about restarting their statin. You just need to be conscious that you should recheck it and make sure that it isn't raising LFTs again to a significant degree.
And remember the ranges. So like for a DILI, most of the time it's more than 5 times different than normal, but DILI is one of the few things that can cause your liver enzymes to be more than 10 times different. When you're seeing it that sort of 2 times upper limit normal range, even if you look at these guidelines, it's monitored where it's actually safe and okay, you need to keep going with those meds unless it's, as long as that number isn't climbing into the 2 to 5. And that's when the institute guidelines will tell you to stop meds and investigate. But usually up to 2 times after normal, because what most of the stuff.
Did you read any guidance on when to be performing a liver biopsy for these patients?
So liver biopsy for these patients in particular, I think is only really done once you've hit a wall of like uncertainty in your diagnosis. So this case report that was initially done was a patient, and the reason that they were on prednisolone for part was a patient that had autoimmune hepatitis as well. They had a history of autoimmune hepatitis as well as now this presentation of painless jaundice. I specifically left it out of this talk for the reason that I didn't want to confuse everybody with like 2 etiologies that could be going on. And I wanted to focus in more on like the drug reaction that we're having. In her case, she got a liver biopsy. And I think that was partially done because they wanted to prove that her autoimmune hepatitis wasn't now escalating and getting worse, and that